Hello everyone. Today we are going to discuss about inflammatory bowel disease. So what is inflammatory bowel disease? It is basically an idiopathic disease caused by dysregulated immune response to host intestinal microflora. The signs, symptoms and complications of IBD is related to severity and extent of inflammation of the gut wall. There are two types of IBD, that is ulcerative colitis and Crohn's disease. These are the types of IBD. Then what is ulcerative colitis? Ulcerative colitis is inflammation and morphological change confined to colon and rectum. You have to remember this, that if it is confined to colon and rectum, it is ulcerative colitis. Rectum involved in 95% of patients and variable proximal extension. So the proximal extension, how it is spreading proximally, it is variable in every patient. Inflammation is limited mainly to the mucosa. It is mainly limited to the mucosa and the depth is not way deeper than the mucosa. It is limited to that layer only, not deeper than that. Features: ulceration, edema, hemorrhage along the colon. So what is Crohn's disease? It can affect any part of GIT, starting from mouth to anus. This is the differentiating point in Crohn's and ulcerative colitis. Disease segment separated by normal bowel, that is there are skip areas. So it will have skip areas starting from mouth to anus. It is not in continuous manner. It is mainly in skip area. In one part it is Crohn's disease is affecting one part, then it will skip the healthy skin, then it will affect the other part. So it happens in a skip area. Inflammation can be transmural. Transmural means it will invade all the layers. As we have seen earlier, ulcerative is mostly confined to the mucosa, but Crohn's may extend to the serosa. Complications will be sinus tract. As it can extend to the serosa, it will form a tract, a sinus tract, which will be connecting the other parts. And fistula formation. Most common site, ileocecal region is the most common site. Both diseases are associated with aberrant immune response. So basically it's the immune response which is culprit here, to commensal microbiota of the gut in genetically susceptible individual. However, current treatment focuses on immune-based therapies because important role of cytokines in disease pathogenesis. Within the Crohn's disease, increased level of interleukin 12, interleukin 23, interferon gamma, TNF alpha are characteristics of Th1 mediated inflammatory process. Whereas for ulcerative colitis, it resembles aspects of that mediated by Th2 pathway, including interleukin 4 and interleukin 13. So basically Crohn's act via Th1 and ulcerative act via Th2. And what are the inflammatory mediators? You have to keep that in mind. Pharmacotherapy of IBD. So these are the pharmacotherapy. First is mesalamine based therapy, then corticosteroids, immunomodulators, biologic and antibiotics and probiotics. We'll discuss this one by one. So first, starting with mesalamine based therapy. Mesalamine based therapy is the first line treatment for mild to moderate cases of ulcerative colitis. It generally involves 5-aminosalicylic acid. So 5-aminosalicylic acid based treatment is abandoned for Crohn's disease. Why? Why it is only used for ulcerative colitis, not Crohn's disease? Why only ulcerative colitis? Because their anti-inflammatory effects are targeted topically to the mucosa with limited effect on deeper inflammation. Hence, Crohn's disease cannot be cured via this therapy. The 5-aminosalicylic acid, that is 5-ASA, exert local anti-inflammatory reaction, yet the mechanism is not clear. The possible mechanism includes is first, it inhibits COX and LOX synthesis, which inhibits prostaglandin and leukotriene synthesis. So this pathway will be inhibited. Second, it inhibits the immune cells, which will inhibit the cytokines PAF and TNF alpha. PAF is platelet activating factor. It is the platelet activating factor. Then it inhibits the free radicals which inhibit the antioxidant activity. The key medication in this class is sulfasalazine. So in mesalamine based therapy we have the medication is sulfasalazine, which has 5-ASA linked to sulfapyridine group which is linked by azo bond. This is what you have to remember, and the mechanism includes: first, it inhibits the COX locks, second, it inhibits the immune cells, third, it inhibits the free radicals. So this is the structure of sulfasalazine, in which there is salicylic acid, sulfonamide, and the azo bond. This is the azo bond. Its original agent of it is the original agent of 5-aminosalicylic acid class that delay absorption by complexing 5-ASA with sulfapyridine. The complex is cleaved by bacteria. You have to remember this enzyme azoreductase, which is present in lower ileum and colon. Okay, so sulfasalazine is broken down by azoreductase in lower ileum into 5-aminosalicylic acid and sulfapyridine. Absorption: about 20 to 30% of the orally administered sulfasalazine is absorbed in the small intestine, whereas 70% reaches the colon where it is cleaved. 5-ASA, it is poorly absorbed from colon, with most of it being excreted in the stool. A small amount is absorbed and then acetylated in the intestinal wall and liver before excreted in urine. So we have seen sulfasalazine is a prodrug. It is broken down by bacteria in sulfapyridine and 5-aminosalicylic acid. The 5-aminosalicylic acid has anti-inflammatory action, whereas sulfapyridine has antibacterial action. The antibacterial action, the sulfapyridine, will be absorbed in the blood, whereas 5-aminosalicylic acid will be moved out by feces as it is poorly absorbed. The sulfapyridine group, which is rapidly absorbed from colon, this sulfapyridine group, which is absorbed from colon, undergoes extensive metabolism in liver before its excretion in the urine. The patient acetylation phenotype, that is how quickly they metabolize the drug, it determines the level of sulfapyridine in the plasma and likelihood of its side effect. Adverse effect: as this is a drug, so whenever the drugs that have sulfa moiety, they cause numerous side effects like nausea, dyspepsia, headache, interfere with the folate absorption that leads to hemolytic anemia and agranulocytosis. Folate is B9. It decreases sperm count and motility. If used, sulfasalazine should be given with food, initially with low dose 0.5 gram orally BD, then dose and frequency is gradually increased over several days to 1 to 1.5 grams 4 times a day. Patient should take folate supplements along with it, that is 1 milligram orally, and have CBC and liver tests done every 6 to 12 months. To preserve the therapeutic effect of 5-aminosalicylic acid without the adverse effect of sulfapyridine, several second generation 5-ASA have been developed. So after that, there are various drugs which have been developed, and they are divided in two groups, that is prodrug and coated drugs. Prodrug contains same azo bond as sulfasalazine but replace the linked sulfapyridine with another 5-aminosalicylic acid, as we can see in drug all-salazine. In all-salazine, there is 5-aminosalicylic acid plus 5-aminosalicylic acid, whereas earlier we have seen in sulfasalazine there is sulfapyridine and 5-aminosalicylic acid. But here there is no sulfapyridine, there is only 5-aminosalicylic acid, but they are linked with azo bond. Okay, and then we have another class, that is balsalazine, where inert compound like 5-aminosalicylic acid plus aminobenzoyl beta-aniline is used. This is the another combination. Then we have mesalamine, mesalazine. Mesalazine has acid resistant 5-ASA. So mesalazine is used in delay release formulation or pH sensitive coating. So as we have self-salicine, we have other class of drugs also like all-salicine, belsalicine and mesalazine. Okay, all-salicine, besalicine and mesalazine. First is all-salicine. All-salicine consists of two compounds of 5-ASA. It is coupled together by azo bond, poorly absorbed in ileum, and the azo bond split in colon to give 5-ASA locally. This 5-ASA locally, we have seen earlier, the 5-ASA has anti-inflammatory action. It acts locally in the intestine. It does not go into blood. It acts locally and give its anti-inflammatory action in IBD. Whereas the sulfpyridine goes in blood and shows antibacterial action. So 5-ASA will act there locally and there is no separate carrier moiety. As we have seen, there was sulfpyridine along with 5-ASA, but here there is no carrier moiety. Dose is 1000 mg per oral. Adverse effect is diarrhea, especially with pancolitis. It can be reduced with gradual escalation of dose and administration of meals. Belsalicine consists of 5-ASA linked with 4-aminobenzoyl beta-alanine as a carrier. So in this drug we have a carrier. Unlike sulfpyridine is inert. The ASA is released in colon and carrier is poorly absorbed. Dose is 2.25 gram per oral 3 times a day. We have mesalazine. It is also known as mesalamine or 5-aminosalicylic acid. It acts similar to sulfasalazine, used to treat IBD including ulcerative colitis and Crohn's disease. It is formulated as delayed release. So it is delayed release preparation or has been coated with pH sensitive acrylic polymer. So that release of drug occur only in colon. It will not metabolized or it will not show its effect until it reaches the colon. The coated formulation delivers 5-ASA to the distal small bowel and colon. Dose is from 1.2 to 4.8 gram in 3 divided doses depending on the severity of the disease for 6 weeks and then reduced to lower maintenance dose. Next class of drug we have corticosteroids. It is useful for acute flare-ups of IBD when 5-ASA compounds are inadequate. It is not appropriate for maintenance therapy. For severe disease, we'll give IV hydrocortisone and IV methylprednisolone. And for moderate disease, we'll give oral prednisolone and continue until the symptoms remission. Tapering schedule, we have to reduce by 5 to 10 mg weekly until 20 mg once daily. Dose is given. Then taper by 2.5 to 5 mg weekly based on clinical response. Maintenance therapy should be started with 5-ASA or immunomodulator during the tapering. We have to keep that in mind. Topical therapy, we have hydrocortisone enema or foam used for proctitis and left-sided colitis. Dose is 100 mg in 60 ml isotonic solution given once or twice daily. Administration, patient lies on left side with hips elevated to prolonged retention and distribution of the drug. Treatment schedule, daily for 2 to 4 weeks if effective, then every other day for 1 to 2 weeks and gradual discontinuation over 1 to 2 weeks. Now we have immunomodulators in which we have azathioprine and 6-mercaptopurine. These are purine analogs and both are prodrugs. Mechanism of action is they inhibit T cell. It will inhibit the T cell and induce T cell apoptosis. Indication used in both ulcerative colitis and Crohn's disease and indicated for moderate to severe cases. So we'll see the metabolism of 6-mercaptopurine. So there are 3 metabolic pathways in which the 6-mercaptopurine is metabolized. It is either metabolized by xanthine oxidase, by TPMT, that is thiopurine methyltransferase, or by HGPRT. If it is metabolized by xanthine oxidase, it will convert to 6-thiuric acid, which is inactive and it is excreted out. But if it is metabolized by TPMT, it converts into 6-MMP and cause liver toxicity. Whereas if it is metabolized by HGPRT, it will form 6-thioguanine nucleotide, which is active and gets incorporated in DNA and RNA and cause toxicity and immunosuppression. So these are the 3 metabolic pathways. Here is the diagram. You can also see if it acts via TPMT, if it acts via xanthine oxidase, if it acts via HGPRT, it will form its metabolite. Okay. Now, difference in TPMT determine drug's fate. If patient with minimal TPMT activity, this TPMT, second one, which will cause liver toxicity. If patient has limited TPMT activity, the metabolism shifted towards 6-thioguanine nucleotide. That is, if the patient has problem in metabolizing via this enzyme, so the pathway will be shifted to other way. Okay. And the patient with minimal TPMT activity will cause bone marrow suppression and weekly monitoring of CBC is required. But if they are rapidly metabolizers, if the patient is rapidly metabolizers, if they have gene which will cause the metabolism of TPMT very fast, which causes metabolism via TPMT very fast, it will shift towards 6-MMP. That is, this pathway will remain activated. This 6-MMP. This pathway will remain activated if the patient is a fast metabolizer via TPMT. But if the patient is a slow metabolizer via TPMT, the pathway will be shifted towards other way, because this will not work. So drug interaction, allopurinol prevent conversion to inactive metabolite. So more active metabolite accumulate and there is toxicity risk. This is the drug interaction when it is given with 6-mercaptopurine. It prevents its conversion and so toxicity will be increased. Benefits: effective for long-term management, reduce corticosteroid requirements, maintain remission for years. Onset of action 1 to 3 months. Corticosteroid should not be withdrawn for the first 2 months. Adverse reaction: idiosyncratic, which is pancreatitis, fever, rash, arthralgia, nausea, vomiting. Dose related is suppression of bone marrow, elevation of liver enzymes, and serious includes malignancy like non-Hodgkin lymphoma. Dosage: azathioprine is 2.5 to 3, 6-mercaptopurine is 1 to 1.5. Dose varies with individual metabolism, and dose should be reduced by 50% in certain cases and adjusted based on clinical response and hematological monitoring. Okay, so we have studied about azathioprine and mercaptopurine. You have to keep this in mind that azathioprine is the one which is converted into 6-mercaptopurine, and then all the metabolism, that 3 pathways happen. Here azathioprine is converted to 6-mercaptopurine and all the 3 pathways happen after that. So before starting these drugs, patient should undergo test to measure the activity of thiopurine methyltransferase, that is this. Okay, because it has various level of toxicity. Then methotrexate, its mechanism is dihydrofolate reductase inhibitor. It is a dihydrofolate reductase inhibitor, thereby blocking the DNA synthesis and cause cell death. It has immunosuppressant and anti-inflammatory properties. Dosage is 15 to 25 mg given orally and sub-Q once weekly. It's indicated in Crohn's disease and ulcerative colitis, but its role in ulcerative colitis remains controversial. It is benefited even in patients who are unresponsive to azathioprine and 6-mercaptopurine. For that case, methotrexate are given. Common adverse effect: it inhibits the renal excretion of methotrexates like NSAIDs, phenytoin, ciprofloxacin, propanacid, amiodarone, and cause toxicity. Nausea, vomiting, other adverse effect, and asymptomatic liver function abnormalities are the adverse effect. Management: folic acid is also given, that is 1 mg per oral once daily to reduce some side effects, and CBC and liver LFT tests are usually given every month for the first 3 months of therapy and then every 8 to 12 months during the ongoing therapy. Next we have cyclosporin, which blocks the lymphocyte activation. It is indicated in ulcerative colitis for patients unresponsive to corticosteroids and biological agents, and it helps avoid colectomy. In Crohn's disease, it has limited role and beneficial in refractory fistula and pyoderma. If we'll talk about dose, initial 2 to 4 mg per kg IV as continuous infusion over 24 hours, and maintenance is responders are switched to oral dose of 6 to 8 mg per kg once daily with early introduction of azathioprine or 6-mercaptopurine is recommended. Long-term use, that is more than 6 months, is contraindicated due to multiple adverse effects like renal toxicity, seizures, opportunistic infection, hypertension, and neuropathy. Now we have small molecule drug, that is tofacitinib. It is approved, FDA approved for moderate to severe cases of ulcerative colitis and in adults who do not respond to other therapies, but it has limited effect and benefit in Crohn's disease. If we'll talk about its mechanism of action, it inhibits the JAK1 and JAK3. So it interferes with the JAK-STAT signaling pathway. So when in receptor, if the substrate will bind, it will activate JAK and then STAT, and that will cause the DNA and protein metabolism. So this is the pathway which normally so it interferes with the signaling which normally transmit extracellular information to the cell nucleus. This pathway regulates gene DNA transcription. By blocking it, the drug reduces inflammation and immune response. There are other examples in this group, that is baricitinib and upadacitinib. So this is the pathway. When the cytokine receptors get activated, JAK will give signal to STAT, and STAT will phosphorylate and dimerize and goes to the nucleus for transcription and translation and giving all the information. And this is inflammatory loop. It will also cause more cytokine production and then the loop will goes on. But tofacitinib will control the JAK-STAT pathway by inhibiting this pathway. Then we have small molecule drug like SIPR modulator. This is sphingosine-1 receptor modulator. It is a drug that interferes with the sphingosine-1 phosphate receptor on lymphocytes, preventing them leaving lymph nodes, thereby decreasing their migration in CNS, thereby decreasing inflammation in condition like multiple sclerosis. But it is also used in IBD. Ozanimod is the drug that is marketed as Zeposia, is the first approved by FDA in March 2020 for multiple sclerosis, and later in May 2021 for moderate to severe case of ulcerative colitis, which is a type of inflammatory bowel disease. Next we have anti-TNF drugs. These are biologics. These are monoclonal antibody to tumor necrosis factor. What it does, these drugs bind and neutralize soluble and membrane-bound tumor necrosing factor on macrophages and activated T lymphocyte, prevent TNF stimulation of effector cells. We have drugs like Infliximab, Adalimumab, Certolizumab, and Golimumab, and they are used in both. Infliximab, it is indicated for both. Dose is single IV infusion of 5 mg per kg over 2 hours and repeated at 2 week and 6 week, then every 8 week. Dose adjustment may need increased dose or shortened interval within a year, and therapeutic serum level is 6 to 10 microgram per liter. Adalimumab, it is also given in both cases where loading dose is 160 mg sub-Q, then 80 mg sub-Q at second week, then 40 at every 2 weeks. Therapeutic serum level should be 8 to 2 microgram per minute, microgram per ml, and special note, effective in patient intolerant to or who's lost response to infliximab. Then we have certolizumab, which is approved for Crohn's disease. Doses 400 mg sub-Q and repeated at 2 to 4 week. It is pegylated fragment of human monoclonal antibody and has high affinity for TNF. Those which are pegylated means they will be more potent and will have long lasting effect. useful in patient intolerant to or non-responsive to infliximab. Then we have golimumab, approved for ulcerative colitis by FDA in 2013. Initial dose 200 mg sub-Q, then 100 mg sub-Q at second week, then 100 mg sub-Q at every 4 weeks. Special note, alternative for patients who failed infliximab. Monotherapy with anti-TNF agents is effective for both induction and maintenance of remission, and combination therapy with thiopurines such as azathioprine or methotrexate may yield better long-term outcomes. There are other biologics which are non-TNF drugs. These are Nitalizumab, which is a humanized monoclonal antibody against alpha-4 beta-1 integrin, which is addition molecule where alpha-4 integrin is required for addition, transmigration and diapetesis mechanism of WBC. US FDA approved Nitalizumab in 2008 for treatment of moderate to severe Crohn's disease, whereas Vedolizumab is a monoclonal antibody approved by US FDA in 2014 for treatment of ulcerative colitis and Crohn's disease. It acts as anti-inflammatory by blocking alpha-4 beta-7 integrin. This inhibits alpha-4 beta-1, this alpha-4 beta-7. Here we can see alpha-4 beta-7, alpha-4 beta-1 receptors inhibited by Nitalizumab. This is Vedolizumab, endothelial cell which have VChem which attaches here, and there are E-catherine, so leukocyte, and these are the cells. So these are inhibited by various drugs. Then we have Uskedinomab. This is fully humanized monoclonal antibody that prevents activation of interleukin 23 and interleukin 12 and received approval for both in 2016 and 2019. Originally developed for treatment of psoriasis, and it is effective in induction and maintenance of remission of Crohn's disease. Initial treatment is given IV at dose 260 to 520 mg depending on the body weight, and then 90 mg sub-Q every 8 weeks thereafter for maintenance of remission. Then we have antibiotics and probiotics. Antibiotics may be helpful in Crohn's disease, but it is of limited use in ulcerative, except in toxic colitis. First, metronidazole 500 to 750 mg per oral 3 times a day for 4 to 8 weeks may control mild Crohn's disease and help in healing fistula. However, adverse event may cause neurotoxicity, often preclude completion of treatment. Next, we have ciprofloxacin 500 to 750 mg per oral may prove less toxic, and many experts recommend metro and cipro in combination. Then we have rifaximin, a non-absorbable antibiotic at dose 200 mg per oral 3 times a day and 800 mg per oral BD, beneficial for active Crohn's disease. Probiotics, various pathogenic microorganisms given daily serve as probiotics and may be effective in preventing pouchitis, but other therapeutic roles have yet to be clearly defined. The therapeutic infestation with parasite treacherous Swiss have been tried in an effort to stimulate T2 helper cell immunity and decrease the disease activity in ulcerative colitis. We have targeted drug delivery for IBD like budesonide nanosuspension. These are being developed for IBD to improve drug delivery to inflamed colon tissue, as current treatment can be limited by mucus in the colon. So this can be helpful, these nanosuspension, by reducing the size of budesonide particles and incorporating muco-inert coating. These nanosuspension can penetrate the mucus layer, leading to better targeting to the inflamed areas. This enhanced drug delivery result in high drug levels in the colorectal tissue and potentially great therapeutic efficacy with less systemic exposure compared to standard budesonide formations. Why budesonide nanosuspension are significant? Because while a topical such as enemas is common strategy for treating distal IBD, its efficacy can be limited by poor mucus penetration. Novel drug delivery system like nanosuspension represent an innovative approach to overcome these challenges, offering a way to improve local delivery of budesonide where it is needed the most. We have Mirikizumab. It is interleukin 23 inhibitor approved by FDA on October 26, 2023 for treatment of moderate to severe ulcerative colitis. The approval for Crohn's came later in 2025. We have Upadacitinib, that is JAK1 inhibitor, approved in May 2022 by FDA for ulcerative colitis, and for Crohn's in May 18, 2023 for oral agent approved for moderate to severe Crohn's disease. So these are the drugs we have studied. 5-ASA, which includes sulfasalazine, mesalazine, osalazine and basalazine. They have different combination. These have 5-aminosalicylic acid plus sulfpyridine group. These have different combination, that is 2,5-aminosalicylic acid. These have different. So all these have different groups. Mesalazine has resistant 5-aminosalicylic acid, which will have longer and have effect on the particular location of the body. Then we have corticosteroid. In this we have studied different drugs. We have immunomodulator, in which we have studied about azathioprine and 6-mercaptopurine and methotrexate, how the metabolism of azathioprine and 6-mercaptopurine happens. Okay. Then biologics, we have studied infliximab, adalimumab, certolizumab and golimumab. In biologics, we have studied vedolizumab and ustekinumab. In antibiotics, we have studied cipro, and probiotics, lactobacillus. So that's all for today. Thank you guys for listening to us and listening to me, and follow my channel for more such videos, and please subscribe. Love you guys.